So, I mean, just to cut to the chase, and then I'll back up and fill in some details. I think as an agency, CDC doesn't go along with this recommendation as you might have expected. And our own strategy right now is that we don't post out to any guidelines. We did, you're right, we used to. We don't now. We don't post to IDSA. We don't post to ILADS. Our strategy has been to talk about the critical, what we consider fairly non-controversial, critical information that patients, that physicians, healthcare providers need to treat acute Lyme disease. And I'll read a statement from our website. Treatment regimens listed in the following table are for localized early Lyme. The references below, WHO 2016, Sanchez 2016, so we go back and cite the original clinical information, not guidelines, are for treatment of patients with disseminated late Lyme disease. These regimens, the ones that we're posting, are guidelines only and may need to be adjusted depending on a person's age, medical history, underlying health conditions, pregnancy status, or allergies. So we leave a lot of room for clinical judgment in that. And I guess the thing that, this gets more into the next recommendation than the first one, but pretest probability is really critically important to the sensitivity and specificity or reliability of any test. And talk about coronavirus right now, case in point. If you started testing everyone in the United States who had a cold and upper respiratory illness, you would get hundreds, if not thousands, of false positives without considering whatever other risk factors are there. But that aside, here's what, I guess, what drives us as an agency. Pat, in all due respect, you and Acute both, you talked about Lyme disease patients, and I think you're talking specifically about Lyme disease patients with persistent symptoms. I mean, when we did our calculations on the numbers of Lyme disease cases in the United States, those estimates of over 300,000 cases, those were equalized to make sure that those patients came from we looked at the epidemiologic, the demographics of those patients. They were not from all 50 states. They were, by and large, almost exclusively from where the surveillance data said that they were. They were from those 15 high-incident states. And they also coincided in terms of the demographics of the patients, the risk age groups, you know, children 5 to 10 years of age, adults 35 to 45 years of age, those two peaks. They were approximately 51% male, 49% female. And those things fed our historic surveillance data. They also were characteristics of those patients of that 300,000. So people at CDC would argue that the vast majority of Lyme disease patients are actually served quite well by the guidance that we have at our website, that the diagnostic test is reliable in terms of it's telling you what you expect to hear, you know, in those cases. Yes, you know, 60% of patients early in Lyme are not seropositive because we don't expect them to be seropositive, you know, right at the time they have an EM rash. So, I mean, but all the things in consideration. So we see two diseases, disease A and disease B. Disease A is supported by the 300,000, you know, numbers that we have. And disease A are patients that would present, you know, among other things, with EM rash, with summer flu type illness from states that have high numbers of Ixodes scapularis, which are the vectors for ticks, for tick vectors for Lyme, or Ixodes pacificus. And that these patients by and large respond, by and large test consistent with the diagnostic test, by and large respond to the antibiotic therapies that we recommend, and that these lives are saved of early Lyme disease, in early Lyme carditis, and that they fit these demographics that we mentioned. But then we have, and if you read the latest LymeDisease.org report, there was a talk about, discussion about discordance in, representations of patients. But many diseases, patients with disease B don't fit that demographic at all. They're from all over the United States. They may have no history of a tick bite that they know of. They may not live in places where ticks are even a problem, Ixodes scapularis. Really, there are lots of states where ISCAPs are not there at all. And that's why we're doing tick surveillance. And so disease A and disease B, and I think our folks, to get to the point, our folks at CDC feel like when we tell clinicians that we don't know anything about Lyme disease, there's great discrepancy. You really don't know when to test and when not to. You really don't know. You could either treat them one way or another way because it really doesn't matter. We feel like it's created more confusion and causing a greater harm to that 300,000 people that are out there. And we feel like that there is a great need to close this gap. The research needs to determine what's going on in patients with persistent symptoms. We're not saying that it's not associated with Lyme disease. More needs to be done, but we feel like by saying things like these regimens are guidelines only and may need to be adjusted for all these reasons, our view at CDC is that that is the way we best serve the medical community and the patients.
Well, I respect you, and I respect what you say, but I'm very sorry. More needs to be done. When the hell are you going to do it? I'm sorry, but it's been 45 years that, and I'm sorry that I sound frustrated. I'm frustrated on behalf of all these people that I have sat with and have gone to meetings, gone hoarse with and cried with, and so on and so forth, because nothing is being done, and it seems like nothing is changing. There's still the resistance. All we're asking for is these guidelines and the talk about the state of the science, and yet the agencies don't want to do anything about it, and yet the doctors look there. If you don't have it there, they're looking for it. They're looking for direction. And so they get their direction generally from the agencies. That's why we have so much trouble with mainstream doctors not doing anything. And you don't say you do say that little bit. I was on that phone call with, when you put that piece together for the acute disease or whatever, and so on and so forth. And certainly that's appreciated, but it isn't good enough. It's not something that's out in your face, that this disease is so, has so many diverse aspects and affects everybody so differently. And you have two very well reputable, and it's reputable, it's published in reputable peer review, showing that, that Lyme indeed is probably partly a persisting infection. Some of it may be, inflammatory and, autoimmune and all that stuff, but that persistence, it's probably there. That's what some of the latest studies, as you know, and I know out of Hopkins, out of Northeastern, and biofilms and persisters and everything else. And so this has to change. This is I don't know why you can't see. It has to come from the top down. It has to come from the top.
And I agree, and I share your frustration. I was reading from my files a 1991 New York Times article that I saved, and it could have been written yesterday about the controversies of Lyme, and it's heartbreaking, it's tragic, it's a failure, a failure of public health. But I don't think
was it called that? Was that the one that said patients was mass delusions, or was that one of the other?
No. It wasn't that, and I would be glad to share it with you. But I think that we have ways that we can address this, and we can change the maps. We are working on better ways to show those maps, and the whole idea of high and low incidence was a response to endemic and non-endemic, which was, the criticism a few years ago. And I think that we can go to county levels and so that whole states don't look, low endemic, when in fact states are quite different from one part of the state to the other. And we have ways of showing that, and we're committed to doing healthcare provider education to increase the awareness of Lyme disease in areas and to put that in people's mind and to dispel this idea. So
Are you
we're
committed
glad
to
work
saying there are two standards of care? There are two competing guidelines?
We're not, and because those guidelines are so juxtaposed to one another, we feel like that the view of the agency is that would be more confusing and do more harm for the larger number of patients that have less controversial clinical outcomes.
Our time for use of the building has expired, and it's time for us to call an adjournment for the day and meet tomorrow morning.